Good evening, everyone. Welcome you all for this fourth smart class of this year, from ISU. Welcome you all for this very interesting session. Madam is here, Chairman ISU, Sujata ma'am, and all seniors who are joined for this program. Welcome you all. Good evening. So this smart class is very interesting, related to male infertility. We have two experts in this field. Dr. Karthikeyan, he doesn't need introduction. He is well known in this field. He has been on so many podia presenting his work. Today's topic is Azoospermia, case-based approach and operative techniques. Dr. Karthikeyan, who is working in Apollo Chennai, and Dr. Sanjay Prakash from IIMU Chennai. Over to Dr. Karthikeyan.
Good evening, sir, and good evening, everybody. Thank you, madam, and thank you, sir, for the introduction. Thank you, USI, for the opportunity to have a session on azoospermia today. So we thought this azoospermia is haunting again and again. Nowadays, we are seeing a lot of patients with azoospermia, and we see a lot of referrals now coming in from our colleagues from reproductive medicine and gynecology. Patients are also now looking for urologists and andrologists to have azoospermia, like they want us to deal with their disease. So we thought we should educate our youngsters about this topic, and so I thought of discussing Dr. Sanjay, and we came up with an approach of we will discuss two cases. So by the end of each case, we will have a learning objective of understanding that case, and also we will present some related surgical videos because in the end we have to do these surgeries to retrieve sperms. So without much time delay, I will ask Dr. Sanjay to present the first case, and then I will present the operative videos, and then we will have a small discussion and then proceed for the second case. Sanjay, you can share your screen and start. Maybe we will have 8 to 10 minutes for the first talk. Slideshow. Yeah, you can start.
Right, sir. Thank you, sir. Good evening, everyone. I'd like to thank the USI and Karthikeyan sir for the opportunity. Today, let's discuss about two different scenarios where the patients present with azoospermia and how do we proceed with managing them. Yes, the first case is we have a young couple here married for 2 years who came with the infertility evaluation, a case of primary infertility. The female partner has regular cycles and evaluated to be normal. Semen analysis shows the volume of 0.7 ml, fructose negative azoospermia. That is even after centrifugation, no sperms are found in the pellet, and repeat semen analysis also reveal the same. Here, 2 points are important. One is the fructose testing. Although the WHO 2021 manual has discontinued fructose testing, fructose still gives us a lot of information. Suppose the fructose negative means there's probably obstruction at the level of the distal seminal vesicles or the ejaculatory duct. And whenever there is a report which says that the patient has azoospermia, it is always important that the entire semen volume has to be centrifuged, and then the sediment has to be re-examined under microscope. This sediment is what known as the pellet. And then if there are no sperms found, then only he can be termed as azoospermia. Now, what are the points that has to be noted in the history? This is most likely a case of obstructive azoospermia, straightforward case. These are the points. We have to first ensure there is whether proper sample collection, whether the patient has diabetes, any previous surgeries like the pelvic surgeries or any RPNLD, because these can give rise to neurogenic failure, ejaculatory failure, or even retrograde ejaculation. Is there any trauma, recurrent history of UTI, sexually transmitted infections, GUTB? Since it's a case of obstruction, history into the cystic fibrosis symptoms should also be asked, like recurrent chest infections and pancreatic insufficiency. So what is the next step? This is the most important part, the clinical examination. So the patient clinically looks good. The secondary sexual characters are well developed. The penis is normal, no clinical varicocele. The patient does not have VAS. That is a bilateral VAS absent. VAS is generally felt as the classical teaching is the telephone cord consistency, which keeps slipping between the fingers while palpation. The testis volume looks adequate and the epididymis is full. Now the clinical diagnosis based on the patient history, clinical examination, and the semen analysis is mostly obstructive azoospermia, and it is the case of congenital bilateral absence of vas deferens. What is the next step? Next, we have to proceed with the investigations. This is mostly a clinical diagnosis only, but still we need certain investigations as a baseline before proceeding with the treatment. First is the hormone profile. A basic evaluation, the FSH and total testosterone. Generally, in these cases, these hormones will be normal. Scrotal Doppler is generally done to have a baseline estimation of the testicular volumes. Both the testis volumes looks okay here, and the epididymis has also been documented to be bulky. Some of the radiologists will be able to tell us about the absence or the presence or absence of the vas as well. And to conclude, to look at the truss. In the truss, we have to know the level. We have to know about the seminal vesicles and whether there is any dilatation of the ejaculatory duct. Is there any other additional investigation necessary in this particular case? Two important investigations are there. First is the ultrasound of the KUB region, because in cases of CBAVD, there's a 5 to 10% chance the patient has a unilateral renal agenesis. In this patient, he has left-sided renal agenesis, which is very important for him, and the patient needs to be educated regarding a single kidney status. The next important one is a CFTR gene mutation testing, which is available in the form of whole exome sequencing or the next generation sequencing. The importance of this is that in these couples, if one of them has a mutated CFTR gene and the other one has a normal CFTR gene, the child is at a risk of about 25% developing cystic fibrosis, and 50% chances the child is likely to be a carrier. But if both the patients have some amount of some type of CFTR gene mutation, there's a 50% chance that the child likely to have cystic fibrosis and 50% chance of having a carrier. But if both the patients have already have cystic fibrosis, then the child is 100% likely to have cystic fibrosis. So the management of this case is these patients, they have the only option of IVF ICSI to have their own child. The sperm retrieval can be done by PISA or TISA. 90 to 95% times we'll be able to get the sperms comfortably by the simple techniques. It's important to educate the patient regarding the single kidney status, and genetic testing is a must that has to be done. If both the patients they test positive, then they will have to given genetic counseling, and PGT, that is pre-implantation genetic testing of the embryos has to be done to select the embryos without cystic fibrosis. And lastly, if there's a high chance of a child developing cystic fibrosis, they should also be given the option of donor sperms. This concludes the first case. Karthikeyan sir, back to you, sir.
Yeah, Sanjay, thank you for that crisp presentation. So can you just project that case summary again once more, the initial slides?
Yes, sir.
Yeah, we have a lot of participants today, so that is good to see. So to summarize Dr. Sanjay's case, so we are discussing here about azoospermia. So Dr. Sanjay rightly mentioned that initially we have to, so these are the most important practice points which I thought I should highlight here, because when we complete this session, we should have a fair idea about what we are dealing with. So case summary, case, yeah. The history and the examination, first history slide, yeah. So we see here that it is a 31-year-old male and 26-year-old female. So whenever we deal with any infertility, so for a male factor, we are going to see only for male factor. So when we are seeing a male partner for infertility, we have to first note what is the wife's age and how is the wife's fertility status. So we mainly check for the oocyte and also the tubes, etc. But when we have a situation where you have azoospermia, if it is a non-correctable obstructive cause, then probably, as in this case, Dr. Sanjay mentioned, it is only IVF ICSI. Probably the tubal testing, etc. is not required. We only have to understand what is the wife's fertility potential and how we have to proceed. So here he has written 26 years, regular cycles, probably everything is okay. Second very important thing, this is a low volume sample and fructose is negative. So two things to note here. One, we have to ask whether the sample collection was adequate and whether the lab processed this sample correctly or not. So whenever there is a low volume ejaculate, we are going to go through all these things to make sure that we have not missed anything. We have to ask the patient, is he comfortable? Was the environment comfortable? Has he done previous test? Was the volume better before? And does he have the similar low volume every time when he ejaculates? And also some forgotten histories like say RPLND or radiation in the past. All these things are also contributory. Going on to the examination, again, very important points to be noted are the testicular volume and the epidermal fullness. So when we come to azoospermia, as he rightly mentioned, bilateral vas aplasia, that is CBAVD, is actually a clinical diagnosis, and ideally the senior andrologists are not in any like a favor for doing any transrectal ultrasound, etc., to confirm the picture. However, good volume testis of more than 15 cc is actually a very good marker that probably the spermatogenesis is good, and vas aplasia both sides. If it is vas present and epidermis palpable, then probably the route is different. But here, since we have had bilateral vas aplasia, it is again reiterating the fact that it is an obstructive azoospermia. Clinically, testis volume is good, FSH is also good. It is in the range 2 to 8. So again, it is probably a good situation for the patient, and transrectal ultrasound is mainly to confirm that the vas is absent, and whether the SV is hypoplastic or normal, it doesn't really change the management, because if the vas is absent anyway, the treatment is going to be surgical sperm retrieval. And last thing, somebody has also raised about the query of the genetic test. So genetic test CFTR whole gene sequence comes to around say 15 to 18,000 or up to 20,000. So here again, if the mutation is seen in both the partners, again we have to see if they carry the same mutations, and if in that case the mutation is same, then probably there is more role for PGT. Yeah. So Sanjay, yes, you can stop your slide share. So this is just to summarize what we discussed. So I will now now I will just present the video based sperm retrieval for this particular case. So we have to also note that whenever we are nowadays posting a patient of azoospermia for sperm retrieval, we usually term it as single stage sperm retrieval, where we incorporate all the techniques, starting from a PISA up to MicroTESE, we do everything. But here we have to again understand some important basic concepts. So as we are discussing here, non-obstructive azoospermia versus obstructive azoospermia. Here we have a uniform sperm production, where in non-obstructive it is a patchy sperm production. And the second thing is, whenever there is a obstructive etiology, we are looking for whether there is a distal obstruction at the level of the prostate seminal vesicle, like the prostatic outflow, or if it is at the level of the vas, or sometimes the obstruction is at the vasoepidermal junction, which we are not able to diagnose by any test. So when we palpate the epidermis, if the epidermis is full, then probably it is more towards an obstruction. The main point to be understood here is, in obstructive azoospermia, it is a homogeneous uniform spermatogenesis, where a needle anywhere can actually help. While in non-obstructive, it is more focal spermatogenesis, which again Dr. Sanjay will discuss in the next case, based on which we will continue the discussion. So we have this table from Campbell, all of us know. We have two main sources of sperms from the testis. One is the epidermis and one is the testis. So we all know that epidermal sperms are mainly more motile, more mature, while testicular sperms are less motile. And the testicular, there are two sources. Either we can do a testicular sperm aspiration or a testicular sperm extraction. The most important point to note here is this point, which every one of us should be very clear, that in a more obstructive etiology, we are talking about epidermal sperm, where we move towards non-obstructive azoospermia, where we have a little aged male, like more than 32 to 35. If the FSH is on the higher side, above 8 to 10, the testis is smaller, less than say 10 to 15 cc. And all these factors put together in a normal volume ejaculate, probably we are dealing with a non-obstructive azoospermia, where if a PISA works, it is very good, but it is probably a testicular sperm which we are looking at. So this distinction is again very important. In our particular case, if clinically the epidermis is palpable, we can do a PISA. Otherwise, we will be doing a TISA. So for PISA, we use a 26 gauge needle with a 1 ml insulin syringe with some media there. We can be also done under local anesthesia under card block with the subcutaneous block. So we hold the testis, we hold the epidermis, we inject this needle perpendicular and we start aspirating. This works usually only in a full epidermis. So if the epidermis is very flaccid and flabby, it is actually not a case of PISA and probably it is not worth to do a PISA. But wherever we have a situation, we do a PISA, especially somebody who is not able to give a sample, somebody who has a clear-cut obstruction, full epidermis, normal volume testis, normal FSH. Probably these are good situations where we are able to retrieve mature motile sperms for which the embryologist also is very happy. So this is how the PISA sample appears. So here we can see that it is almost similar to a normal semen analysis where we find so many moving good morphology sperms. So this is the basic picture in a PISA. So going on to TISA, this can also be done under local, but when I talked about the single stage sperm retrieval, if we are looking at a smaller testis with a small and high FSH, probably we are looking at a TISA bar MicroTESE, so or a TISA open TC MicroTESE. Therefore, we will plan the procedure under anesthesia. However, again, if we are clear about in this particular patient which we are talking, it is a CBAVD. The most likelihood is probably an obstructive azoospermia. We can actually get away with a PISA or a TISA under local anesthesia also. Here we use a 18 gauge scalpel needle. It's a butterfly needle. So we require a 10 ml syringe and 2 straight or curved hemostats to maintain the suction. So what we do is we put the scalpel set inside the testis, perpendicular into this, and somebody is already holding the pressure in the syringe. At least a 10 ml or a 20 ml is used. We do multiple passes in one direction in the testis. And once we are done, we put the hemostats here to maintain the suction. And then we can see the core which is coming out. So this can be done in 3 or 4 places maximum. Usually we go for 2 or 3 sites. And this is how the core can be taken. And this is how the tissue is actually processed in the lab. So up to this, we have to understand here, because this is what happens in the embryology room. Unless we know these things, it is probably very difficult to understand what the IVF specialists are doing. And if we don't understand that, again, it is difficult to be on their terms. So we try to tease each tubule. The sperms from the tubule should come inside, come outside. This can also be checked under the magnification also. This is usually a 10x magnification. And if we get a motile sperm, that is good. But the epidermis is the location where the sperms start maturing and start getting motile. So in a testicular sample, if we get a motile sperm, that is actually good for us. Yeah. So I will stop here and I will pause for a minute for any doubts. So we have some doubts here. Which should we prefer, TISA or PISA? I think, yeah. So PISA and TC don't go together. I think Dr. Sanjay will answer this in the next presentation. After that, we will take this question. Madam has asked the right question. So if it is a clinically, both the VAS are absent and we have a good clinical diagnosis, testis volume, good FSH normal, it is not mandated to do a transrectal ultrasound. Yeah. Sanjay, you can start the second case. So here we have just completed about one part, which is the obstructive azoospermia, which is a typical obstructive azoospermia, which is CBAVD, which carries more chances of having sperms rather than any other obstructive azoospermia where the VAS is palpable. So here it is more likely that this obstructive azoospermia will yield sperms if the clinical things are met with. Now we will go to the second case.
Here we have yet another young couple who are married for 5 years, who came came for infertility evaluation. There's no history of any clinical pregnancies, any miscarriages, or any procedures done in the past, like IUI or any attempt of IVF. They have regular intercourse, no erectile dysfunction. The partner has regular cycles and evaluated to be normal. The semen analysis here shows the volume of about 1.5 ml and fructose positive azoospermia. And a repeat semen sample done about 2 to 3 weeks later also shows the same, a two volume fructose positive azoospermia. Now, this is a little bit tricky. I just want to briefly tell about what could be the diagnosis here. Here, it can be obstructive as well as non-obstructive etiology, because if there is a obstruction at the level of the rete testis or the epididymis or anywhere along the vas, obviously, so there's going to be a obstructive azoospermia. But since the seminal vesicles and the ejaculative ducts are open, fructose it can still be will be still positive. Hence, it is a fructose positive azoospermia. Or else it can be a case of a non-obstructive azoospermia where there's some defect in the spermatogenesis inside the testis. So in such case, since we are thinking both about the obstructive and the non-obstructive etiology here, there are certain important points that has to be noted in the history. So I think firstly, whether the ensure proper collection was there, history of diabetes, testicular trauma, cryptorchidism, mumps, because these can affect the septolis or cell function directly. Any history of previous surgeries, most importantly, bilateral hernioplasty, the laparoscopic hernioplasty, because they can cause obstruction of the vas. Any history of recurrent UTI, sexually transmitted infection, GUTB, recurrent epidermoorchitis. Recurrent epidermoorchitis can cause obstruction at the level of the rete testis as well as the epididymis. Any history of significant medications, as like the chemotherapy medications, methotrexate, anabolic steroids, drug use, because they interfere with the spermatogenesis directly. Radiotherapy, occupational and environmental exposure. So, how do we proceed next? As usual, the clinical examination. So, clinically, the obese gentleman, he has secondary sexual characters well developed, and the bilateral grade 1 gynecomastia could be because of the obesity itself. Genital examination, the penis is normal, no clinical varicose, bilateral vas present, but the testis, although the testis appears firm, but the testis volume is slightly reduced. So clinically, the right is about 10 to 12 cc and left is about 8 to 10 cc, and the epididymis is flat. So based on this history and the clinical examination, this is a case of a non-obstructive azoospermia, most likely than a obstructive azoospermia. Because as Karthikeyan sir already explained here, the testis volume is slightly lower than the normal, and also the epididymis appears flat. So these are the points which are in favor of a non-obstructive azoospermia at the moment. What next? How do we proceed? We require investigations. What investigation is necessary here is a hormone profile workup and a scrotal Doppler. Hormone profile has to be a little bit elaborate here. Here we can see the FSH is high, elevated 11 point. This is either, according to some labs, this may be high or high normal or even high. The LH is also towards the high normal range. The testosterone is in the subnormal range. The accepted testosterone, anything more than 300 is good. The estradiol is 57, hence the TE ratio is less than 10:1, and 17 OHP, which is a marker of the intertesticular testosterone, is also towards the lower side, 0.41. The accepted normal, anything more than 0.5 is considered normal. And a basic scrotal Doppler ultrasound to the baseline document the size of the testis. The right testis is 11 cc and the left testis about 9.5 cc. It is slightly a discussion about the HPG axis. It is important to understand what is the role of the hormones in the sperm production. Both the hormones, FSH and LH, secrete from the anti-pituitary. The FSH acts on the Sertoli cells particularly, and this is what starts the spermatogenesis. And the LH acts on the Leydig cell, which secretes the testosterone. Testosterone is important for the maturation of the sperms and the movement of the sperms. Suppose because of the various reasons, so what happens is that the Sertoli cells goes into a dysfunction. Hence, the brain thinks that the cell is not working, and the brain tries to push start the cells. Hence, the FSH increases, but the cells or the testes, they do not respond. So once the sperm production inside the testis gradually falls, the testis size also keeps falling gradually. And these causes can affect the spermatogenesis at different levels. Hence, the presentation of non-obstructive azoospermia can be as hypospermatogenesis, or it can be a maturation arrest at the level of the round spermatids or elongated spermatids, or there may not be any sperm production also, in case of a Sertoli cell only syndrome. Any other special investigations are necessary in this patient? Yes, the genetic testing and the karyotyping is important, because as per the standard guidelines forming body, they recommend the karyotyping and genetic testing in case of non-obstructive azoospermia or when the counts are less than 5 million. because they constitute for about 15 to 20% causes of non-obstructive azoospermia. The importance of this testing is only for two purposes. One is for counseling the patient, and second is for the prognostication of sperm retrieval. We need to give the patients realistic ideas. In Klinefelter syndrome, if the patient presents early, that is in their the teens or even less than 25 years, it has the highest chance of sperm retrieval, almost up to 50% with MicroTESE. Whereas if the patient has any form of Y chromosome microdeletion, the commonest form is the AZFC, he still has almost 50% chance of sperm retrieval by MicroTESE. But whereas any other forms, like the AZFA, AZFB, or any other combination, it's high likely that there may not be any sperms inside the testis. In this patient, the karyotyping is normal and there were no microdeletions found. So the management options for him is obviously IVF ICSI is the only option for him. The sperm retrieval can be done by multi-quadrant TESA and then a unilateral or a bilateral MicroTESE. Since the testosterone is low here, testosterone is important for maturation of the sperms. It is important for us to optimize this patient before we take him for the procedure. Hence the testosterone, because testosterone level has to be improved and it has to be maintained stable for at least 2 to 3 months. This is why 2 to 3 months is at least the 2 spermatogenic cycles. It can be improved with injection HCG with plus minus aromatase inhibitors, and it has to be maintained between 300 to 350. The patient should also be counseled and given discussed about the donor sperms, as the chance of sperm retrieval is less than 50% here. The last slide is this slide compares the advantages of MicroTESE over a conventional TESE and a TESA. MicroTESE has a highest successful sperm rate, almost 50 to 60%. The tissue removal is only extremely minimal because we remove only the targeted areas. So depending upon the characteristics of the tubules, the testicular damage is also very minimal since we remove only less than 5% of the tissue, and also the complication rates are extremely less. The expected complications are hematoma, fibrosis, or atrophy. And the chance of identification of sperms are better because of the tubule characteristics, which Karthikeyan sir will show you shortly. And most importantly, it can be even in cases of Sertoli-only cell syndrome, we can still identify isolated foci of spermatogenesis, which cannot be done which is not possible with the other techniques. Thank you very much. Over to you, sir.
Sanjay, there is a question on the chat box. What is the dose of HCG? Would you like to answer that?
Yes, sir. Yes, sir. HCG, it is ideal to start with a lower dose. So 2000 international units thrice weekly. But a lot of people also would like to start with injection 5000 international units once weekly. We have to reassess the patient after 1 month. How much is the increase in the LH and the LH total testosterone and the 17 OHP? If it is still not effective, then we have to increase the dose.
Okay. So I think we will complete this. We will have a short summary and then we will take the questions further. So here again, we have a patient of a borderline testis, borderline high FSH, borderline testosterone. So Dr. Sanjay has put all the things on the borderline. That is only to help us to understand how the andrology practice happens in the OPD. So now the things to note here are, this is a 34-year-old husband and a 31-year-old wife with one testis around 10 to 12 cc and the other side it is 8 cc. Clearly the testis are on the lower side. Similarly, we also see that the FSH is 11.9. In the initial discussion also, we discussed that the FSH is usually around 2 to 8, that is the normal level, and above 8 is usually higher. Sometimes we say that this lab value is that much, this value lab is this much, but basically we have to remember that in a well-standardized lab, if the report is about 10, then clearly this is more towards non-obstructive azoospermia. This point is very, very important, because only based on these factors we are going to take the decision and the counseling, because repeatedly in the slides Dr. Sanjay had also mentioned that we should give a donor sperm counseling. But when we take up these patients for MicroTESE, sometimes the patients say that we are not keen on donor sperm. So at that time, the entire treatment algorithm may change. So the second important thing is what is the role of a varicocelectomy, etc. In this particular situation, we did not talk about the varicocele because this is a very straightforward patient which we wanted to discuss. The only discussion here is whether this patient should be posted for a TISA or a MicroTESE. Again, Dr. Sanjay, you would like to take that question, whether you want to post this patient for TISA or MicroTESE.
Generally, what we do in the practice is that we'll perform multi-quadrant teaser. Multi-quadrant teaser generally in the 4 quadrants. So we take it as 12 o'clock, 6 o'clock, 9 o'clock, and 3 o'clock position. And then we do turn both testes and we see. Suppose so there are chances that we can pick up any sperms, anything in these tissue, and we are able to find that. Then that particular site alone, we would like to do the MicroTESE and search for more sperms. But if you're not able to get sperms from both sides, then go ahead with the bigger size testes and the more firmer testes first. So this is what the routine practice we do.
Yeah. So in short, we actually, as I mentioned in the previous first case also, we do what is called a single stage surgical sperm retrieval, where we have multiple options. So we start from a PISA and TISA, but again, in non-obstructive azoospermia, we are not talking about PISA here because epididymal sperms are actually meant for obstructive azoospermia. When the testis is small, when the FSH is on the higher side, it is very less likely that it is obstructive azoospermia. What is the difference? Why we are so much keen on these things is because the pathology is different and the number of sperms even reaching the epididymis may be less. Therefore, probably in an epididymal aspirate, we won't get sperms. Therefore, PISA is not a method for non-obstructive azoospermia. This is very clear. So in the chat also, we had a question like when to go for PISA, when to go for TC. This combination is not the right combination. It can be a PISA/TISA. It is for a obstructive azoospermia, or a good volume test is maybe a mild epididymal fullness, maybe PISA/TISA is okay. But when we have seen that it is a 34-year-old male with a higher FSH, normal volume, fructose positive azoospermia with higher FSH and small testis, the diagnosis is almost certain that it is non-obstructive azoospermia, where the source is only testicular. So the case would be for a surgical sperm retrieval, it is mainly on the testis. So we have TISA, like what Dr. Sanjay told, we do in 4 quadrants. If it is negative, we can either move it with the testicular mapping under the microscope, or we can directly switch over to a open or a MicroTESE. Now again, the question comes, what is the basic difference between an open TC and a MicroTESE is the level of magnification. So MicroTESE is by far the most sophisticated procedure, which has the maximum yield of sperms in any situation. So if MicroTESE is negative in a well done by a correct, like a good center, by the good andrologist, then probably there is no focus yet left for sperms. So we do MicroTESE in non-obstructive azoospermia. So again, this is very clear. This is not obstructive azoospermia. When testicular sperm aspiration is negative, specifically in smaller volume testis, and this is a controversial thing where if we do a MicroTESE in a testicular failure where TISA has given sperms, some people say that MicroTESE can yield better sperms. So that is not for the discussion right now. This is again very well, we have kept straightforward patients because we need to understand the concept. So as I mentioned this slide again, so these into marks actually schematically denote sperm production. So if our needle goes here, here, or in these locations in the blank areas, probably we won't get sperms. But if our needle by chance in that multi-quadrant, if Dr. Sanjay did, and if we hit this area, he would have got sperms. So that is a luck.
Probability.
So are we going to be lucky or not? Nobody knows. So we have to be prepared for the situation. So the next thing is, how does this area appear under the microscope is a dilated plump opaque tubule. So this is the classical description of a tubule which contains sperms, and that tubule when given to the embryologist will have the better chances of yield of sperm. So again, this concept is the most important thing which we want to drive to the audience, that we are trying to identify these areas across a sheet of normal or like uniformly appearing tubules. So we go by a midline scrotal incision. We can also go by 2 paramedian incisions, open in layers, tunica vaginalis, and expose the testis. And we place a transverse incision on the testis. There are people who also do it the other way. So this is how we bivalve the testis. And initially we achieve hemostasis on the tunica. and we start focusing at say around 10 to 15x, the magnification for MicroTESE is up to 25x. So 25x is the full magnification which we use. So initial scanning, we try to see the general architecture and the quality of the tubules, and we look for enlarged tubules. So if on the initial assessment, if at a good magnification of say 20x, we are able to find some dilated tubules, then that is what we are looking at, and that is what all we want. So if we see here, most of the places, they are not okay, but here and there, we are able to find some dilated tubules. So the disparity between the dilated tubules and the atretic tubules. So this is the most important difference we are trying to make out. And this is what we go quadrant by quadrant, and we go along the planes of the testes. This is how we actually go ahead with the step-by-step approach for the MicroTESE. So our main focus is to look for the dilated tubules, which are ideally supposed to stand out against the uniform sheet of other seminiferous tubules. Yeah, again, this is one of my favorite videos. So these are all looking to be similar, while here in this location, we are able to see some dilated tubules. So we are interested only in those tubules. We are not actually interested in the other tubules. So as we go ahead with MicroTESE, we give lesser and lesser amount of tissue. That is again a very important point to note. So we can also split the testes. Okay, go on to the lobule by lobule. All these things we keep doing because we want to see where is that focus of sperm which we can identify. So technically, this, if you see here, it is very clear that all the things look uniformly flat, atretic, not healthy tubules. So in this background, if you are able to see one or two foci of dilated tubules, that is what we are looking at. Yeah. So we achieve hemostasis after we have done the procedure, and we close with proline, sometimes with monogrel, and then the scrotum is closed in layers. So everybody asks us whether MicroTESE is a more damaging procedure because we are opening the testes, biovalving the testes. We are in fact butchering the testes. That is what we are asked with. But what we follow is an anatomical dissection. We don't cause damage to the architecture, and we don't directly go and damage the Leydig cells. Therefore, a well done, careful MicroTESE. Usually, we don't see any drop in testosterone if the baseline testosterone is good, or even if we have a low testosterone to start with, we probably regain the testosterone within 3 to 6 months. So the last slide, very important again, is to have a dedicated operating room time. So many of us here would be practicing andrology along with urology. So we have to note that we also should have dedicated time, and the place where we are going to do the MicroTESE also should have a dedicated good time which is given for the MicroTESE. A good MicroTESE will at least take 2 hours. Initially, it may take longer than that also, because we have to get used to the procedure. The embryologist has to be with us, and everybody in the team also has to understand these things. And we have to have a decent, good quality microscope with the 25x magnification. We many times get questions whether we can use the loop for MicroTESE. So unfortunately, the answer is no, because our magnification expected is at least more than 20x. So any ENT ophthalmic microscope also will do, but a 25x magnification is mandatory to call the procedure as MicroTESE. And it is only a MicroTESE with which, if we get a negative result, we have done a good thorough search, and if it is negative, then only it means it is negative. Otherwise, in the corner of a testis, still there is a sperm which can be picked up. Again, the next thing is embryologist should be next to the OR, because we will be giving so much tissue that we are constantly discussing with the embryologist whether there is sperm or not, how is the quality of the sperm, which focus contains sperm so that we can take more tissue. So all these things we keep acquiring the skills. So if the embryologist is somewhere which is not a practical solution and against the rules of the IVF nowadays, we also need microsurgical skill and patience. So we need patience on the side of the surgeon as well as the embryologist. The reproductive medicine fertility expert also is supposed to be patient, and it requires hours and hours of counseling. So after the result of all this hard work, we may see that sperm, if at all it is moving on a MicroTESE, that is the best thing the andrologist can get. So that concludes the video presentation on non-obstructive azoospermia. So Yes. So Surya Prakash sir has asked a question of if this patient has high-grade varicocele, to correct it before sperm extraction. Before that, we have how to differentiate obstructive and non-obstructive. So I think Dr. Sanjay also mentioned, I also mentioned. So Sanjay, could you summarize it from history to examination and investigations? How do we have like a differentiation between NOA and OA?
So basically, if there's any history-wise, any prominent, it all starts with the semen analysis first. Semen analysis, so we'll have to look at the volume and also the fructose positivity will also give us a rough idea about whether it's obstructive or non-obstructive. Then next comes the clinical examination. Important, as already discussed, the testis volume, adequate volume for Indian somewhere around 15 to 20 cc is normal. Epididymis fullness or flatness. So this one, and also the presence of vas. So these are some points which are suggestive of. With this, we'll be able to differentiate whether it's obstructive or non-obstructive. Want to add something to the history-wise also, sir?
Yeah, again, history-wise, younger patient has more chance of getting sperms. It is not the difference of obstructive versus non-obstructive. Again, in non-obstructive, we have some patients where the probable obstruction is at the rete testis level or vasoepidermal level, which was not picked up on any test, because the picture about the NOA and OA will be almost similar. So these are the cases where epidermal sperm may be positive, or a testicular sperm will be a good quality sperm. So till it is actually okay, or it is like we can diagnose obstructive azoospermia more confidence, rather than like we can never tell on a borderline case whether it is obstructive or non-obstructive. It is like that. So summarizing is like FSH, testicular size, and probably the volume of the semen, which will give us some idea about NOA versus OA. And if this patient had high-grade varicocele, again, varicocele and NOA are actually always controversial. Again, younger the patient, better the outcome. If the testicular size is good, if the FSH is lower, that is also good for us. And if somebody has seen some sperms or some maturation arrest on the TISA or a hypospermatogenesis, this is where these varicoceles will help us. Again, whether to correct the varicocele and then go for IVF ICSI, or we should do the IVF ICSI and if it fails, go for varicocele. If the varicocele, if the patient has NOA, patient has a high-grade varicocele, and on testicular biopsy, if the report is like hypospermatogenesis or maturation arrest, if it is hypospermatogenesis, a correction of varicocele along with freezing of sperms will give us a better outcome. In maturation arrest, we still don't know whether this varicocele is the contributory factor. Still, we freeze if there are good sperms. Otherwise, we do the varicocelectomy and come back for a sperm retrieval after 6 months. Sanjay, do you want to add anything here?
Sir, yes, sir. So as you told about the case selection first. So the varicocele repair case of non-obstructive azoospermia, there's a testicular volume of minimum 10 cc, and also the FSH anywhere less than 10 will give us a positive value. So how we actually, okay, in such cases, we have to still counsel the patient that the chance of retrieval may be less only. You may require another surgery in the form of MicroTESE again. So how's the general practice is? We always do a multi-quadrant TESE and a varicocele repair, not a MicroTESE and then and a varicocele repair. So do this way, and as sir told, if it is hypospermatogenesis, as per studies what we have, there is still good chances that he can have sperms ejaculate, but it may not be enough to conceive naturally. He may still need only IVF, at least avoiding other procedure. But whereas if it's going to be like a Sertoli cell syndrome or maturation arrest, it's still after a varicocele repair also, we may not be able to find out sperms. So generally, the people, that's a difference in how long we have to wait also. So the people generally talk, it's about 3 months. Actually, 3 months is basically 2 spermatogenic cycles. But some people also the practice wait for up to 6 months. So just there are no still consensus or guidelines regarding these lines.
Yeah. So the period of waiting actually depends upon how good the wife's parameters are. If the wife is young, has good ovarian reserve, we can even wait for a longer time. The other thing is to always do a Y chromosome microdeletion and karyotyping before we attempt all these things, because if the YCMD is positive, then probably this varicocele does not have much relevance. So we have two more questions. I think we will be taking only these two and we will be stopping. So Sanjay, 14-year-old boy with a normal profile of hormones, scrotum ultrasound 2.1 centimeter. Semen analysis, I don't know why this situation came to the doctor first of all at 14 years. Yeah, but why Dr. Raghav cancelled why this situation came up? Because in ultrasound also there is no varicocele. So why did the patient come to us first? So at 14 years, what are you thinking about in this particular situation? So point is here, 14-year-old boy, they have done semen analysis and there are no sperms.
Okay, so whatever reason for the thing they have done, so this can be a case of a delayed puberty also. So yeah, so generally the boys reach puberty at a starts around 13 years. So, but sometimes it can go up to 15 years also. The testis volume is also it's slowly starting to grow. In these cases, we have to see whether the child is most of the times when boys of this age they come, they tend to be obese. We have to tell them, okay, have to reduce weight, okay, be more fitter, and we have to reassure the patients and wait. How long we can wait is we can wait up to 15 years. So once every 6 months, we just can see whether his hormones are increasing. Then so this will give us the idea whether it's a case of a congenital growth delay, or it is a case of a hypo or a hypergonadotropic hypogonadism.
Yeah. So to basically start with, actually, we also want to know the hormone profile. So from there only we can start. If the hormone levels show low, then probably a hypo where we can start HCG. We can again discuss the timings, etc. But if the values are higher, then probably it is an azoospermia which was picked up very early. So I think we may still go with the genetic testing and proceed. So that should be the case. I think these are very rare situations. So last thing is this again, always this question haunts us when there is an agrospermia or total asthenospermia. Sanjay, how will you manage? You just start with the definition. So how do we define these conditions? How do we diagnose and then how to treat? Shortly.
As you know, the azoospermia, as per the WHO 2021 manuals, if the progressive motility is less than 32%, and necrozoospermia if the sperm vitality is less than 54%. So these are the definitions. So we have to look into what are the common causes of, or rather, what are the reversible causes of azoospermia. The common reversible causes are like varicocele, hormonal imbalance. Most commonly, it is a hypogonadism.
Sanjay, the
Sorry,
question
I think so.
total asthenospermia and necrospermia. We will leave alone the usual asthenospermia. It's
Okay, sir.
the absolute asthenospermia and necrospermia.
Okay, yeah. So the total azoospermia, necrozoospermia, so most likely is the infection is the first cause here. So we have to do what are the parameters that can actually help us to know whether there is there's infection or not. We have to look into the viscosity. If the viscosity or the liquefaction time is too high, if there is leukocytospermia, and if there is sometimes some blood also in the ejaculate. So these are all some indicators of that there is a probable infection. We can and also clinical history is important, whether he has any dysuria, he has had any epidermal tenderness, swelling. So these are helpful. So we can identify and treat them. And there's also rarely genetic causes of a primary ciliary dyskinesia, which can present as total azoospermia. Here, all other parameters will be now normal. History-wise, retrospective, we have to see whether he has any history suggestive of bronchiectasis. So recurrent chest infections, cough. So these are common factors. So it's basically two things. One is reversible and irreversible. Infection, we can treat them. If it's going to be a primary ciliary dyskinesia, IVF is only going to be the only choice. But IVF normal sperms can be used, and success rate is also compatible to people with normal parameters.
Yeah. So is there a role for a surgical sperm retrieval in these situations?
If the patient does not respond to any of your conservative management, then the last option would be to do a teaser and take the sperms out directly. That's only in case of necrozoospermia. Total azoospermia, if there's no infection, all of the factors are normal, we can use a normal ejaculate sperms itself. But in these cases, the sperm selection, how we do is important. If the sperm is if a testicular sperm retrieval has been done, so it's ideally identification of the sperm by IMSI technique is better, because Normally, a sperm selection will be done somewhere around 200 eggs. But whereas in a IMSI, the sperm selection will be done somewhere around 6,000 eggs, where the 6,000 times magnification, and also the WHO has given particular criteria of what are the normal parameters of the sperm. How much the head should be, how much the neck, how is the neck, how is the midpiece should be, what is the number of inclusion bodies has to be. So based on this, the selection can be done and the sperm selection can be done for IVF.
I think we are going on into a difficult topic. These are topics for discussion by themselves. So I think we will stop there if there are no questions, and I hand over the podium to Dr. Sanjay Prakash sir and Sujata ma'am.
Yeah, that's
Thanks,
great.
Karthik. I think a very nice presentation. Definitely, I think the students would be benefiting from your case presentation. Very well taken cases. I think maybe you could have included a patient with really truly obstructive azoospermia due to any.
Yes, ma'am.
And like how would you or post vasectomy, and maybe that would have completed it. And it was a really nice discussion, and you did it at a very short interval. We are thankful to you and to Dr. Sanjay for your crisp presentations, and I hand
Thank
it
you,
over
ma'am.
to Surya.
Thank you,
Yeah,
madam.
thank you.
Thank you, ma'am.
Before we close, Karthikeyan, I have a doubt. So when you do MicroTESE, when you say that now it is over, you give it up. Time, you put some time, or even if you do remove, take out suppose a 30, 40 spermatogenic tubules, and if it is negative, I mean to ask at what time you say it is
Sir,
not working.
actually, it is not about the number. We only try to look at all the places. So we even go, I showed the video also. We try to explore all the areas. We do superficial section, deep dissection, quadrant dissection. We even go to the poles under the tunica if there is anything. We try to do everything. And one thing is, if uniformly, if the tissues are looking similar, atretic tubules, not opaque, not dilated, then probably this patient is not going to have sperms. But here and there, we are able to see some differences, like we see in many patients. That is where we try to remove all the tubules which are looking different. Once we have sampled on both the sides, all these things, that is when probably after, say, a period of, say, minimum of 1.5 to 2 hours, we have removed enough tissue that the embryologist now says, stop, doctor, this is enough. Till then, probably we will continue, and I think Sanjay will add maybe 1 or 2 additional points.
Would you contemplate on the other side if one side you?
No, sir, it is always bilateral.
Both
So
sides,
one
sir.
side is not there, then we go for the other side. Same thing we do, everything. If at the end of both the sides, we have tried everywhere, we are not getting any difference in tubules. We have taken the tubules given to the embryologist, we have sampled all the places. Still, if nothing is working out, then that is the time when we stop. We also actually try to predict the situation beforehand by doing the entire workup. We do the hormones, we assess the clinical situation. We have talked to the couple about donor sperm, we have understood their pulse, we kept the things ready. All those things also we do. And we are now using newer markers like inhibin B. Like they are not new, but we are now trying to see how these newer markers also help us. And we are always in the quest of looking for newer things which we can help to predict the situation. Sanjay, anything to add?
Yeah. Yes, sir. So in certain situations like this, where the magnification also matters. Some cases where I've gone up to magnification of almost 40x, but this is not routinely available. It's only available in only high institutes where we use a neuro microscope. At that high magnification, we be able to find out some hidden tubules between the tubules, sir. This most likely happens towards the hilum. So when you're exploring a hilum, so gently we have to just find as a one large step, go to the maximum magnification and gently keep seeing towards the hilum. So that area we'll be able to get some tubules. I've got some tubules at this, but still it just depends upon the practice only, sir. It's just a probability. That's all.
The availability of 40x, not probably always, but
Yes.
maybe higher the magnification, this will come, sir. This is what I have also been
I
thinking.
have one more question before we stop, Karthik. One more question for you, Karthik, is like there were in between a lot of new machines which advertise the sperm function tests and various functional tests for the sperms. So do you actually use them in clinical practice?
You're
Yes, ma'am.
talking about CASA, ma'am?
No, sperm function test.
Those functions. Okay.
Yeah,
DNA fragmentation
sperm
and
functional test.
yes, ma'am.
Uh,
Yes, ma'am. In a case of OATS, I think we are very fond of the sperm function tests. But yes, we do use them, madam. Yes.
Acha. Because there was
Complexity-
one machine installed in one of our public hospitals, so we were wondering whether actually it is useful for us in clinical practice.
I think she's
Madam,
talking about CASA, sir, I think.
Not computerized assay
DFI
of
like
the
madam,
sperm
DNA
function.
fragmentation index.
They have multiple tests in their battery. Means I can message you later on. But
Okay.
they have some fragmentation test and they have some
DFI, ROS, Annex and 5, and these kind of
yeah,
tests, ma'am, you're talking.
yeah.
Okay, ma'am. DFI, as per the guidelines, we don't do it routinely, ma'am. So there are certain indications. Suppose if there are recurrent implantation failures, IVF failures, or even IUI failures, where the partner has miscarriages, and also in clinically very significant, that is clinically only grade 2 or grade 3 varicocele. So in these conditions, we do DFI test, ma'am. So otherwise, routinely, patients who are coming as a first line, as the primary infertility, we routinely do not do it, ma'am.
Oh,
and also on a machine, maybe
thank you.
the value of test may not be good, madam. We actually have very specific methods like SCSA, which will be the best method for the DFI, and maybe we routinely do the sperm chromatin dispersion in the labs, which is a second level test. But I'm not very sure how this machine will be very reliable and accurate for especially a DNA fragmentation testing.
Okay, thanks. Yeah.
Thank you. Thank
So,
you.
Surya, we'll conclude.
Sanjay, great presentation.
Thank you,
Yes,
sir.
ma'am. Thank you. Thank you, madam. Thank you very much. We had a very good audience, Dr. Karthikeyan. That itself shows that people have got interest. So I encourage postgraduates or young urologists to take up this specialty,
Yeah.
not just confining yourself to general urology. Yes, madam.
Yeah, I think the format was also very nice, and they
Yes.
together they did it as a nice team. So thank you very
Great.
much. Yeah.
Thank you for giving
Thank
the
you,
idea
ma'am.
of actually case-based and video-based discussion.
Good night.
Right.
Idea.
Thank you.
Yeah. Good night, everyone. Good night.
Thank you. Thank you, everyone. Thank you.